trying to do it right. I've been living a lonely life. I've been sleeping here instead. I've been sleeping in my bed, sleeping in my bed. So show me family, all the blood that I will bleed. I don't know where I belong, I don't know where I went wrong, but I can write a song. I belong with you, you belong with me, my sweet home. I belong with you, you belong with me, my sweet home.
I want to keep this informal, but I want to give you as much information as we can about what's going on with the people in the room who have kids or in their fluid disorders, and all the family and friends who come to support them. And I feel even better now because my resident Vinian's here. He's part of the show as well. Thanks for coming, Vinian. So what we're going to do is I'm going to spend a few minutes talking about what we think is going on with this disease. And I'm going to ask Tanya to say a few words about what we're doing with the fundraising and the website and the gala that's coming up and whatever else she wants to talk about. Dr. Wideman Kadani, who is a surgical resident working in the training in the program here in London, has been doing some statistical analysis of all your people's charts. And he's coming up with some very interesting things that are shedding some light on what's going on. The ultimate goal for this is to figure out what's causing this and fix it. Right now, we're doing surgery and putting you on drugs and things to try and get the symptoms under control, but we're not actually finding the cause and fixing it. So the overall goal is to fix this thing. But along the way, we've got to figure out what's going on first before we can fix it. After Vinian's talk, I thought we'd have a general question and answer session. Please don't get too hopeful that we can cure you tonight. I'm not going to do that. But the main thing I want to get across to you tonight is that you people aren't alone with this. You may have thought that when you first got the symptoms and nobody else in your town or on the street or in the city or in the province had it. There's a whole bunch of people here who have the same problem. So this is not something that's in your heads. This is something that's really happening. It's not in any textbooks, and you've got to figure out how to fix this. And I can tell you, after realizing about 10, 15 years ago something was going on, you've come a long way now in putting a lot of data together, and Vivian will speak a little more to that. So I'll just go into this discussion about what's going on with this disorder. So in your intestinal tract, when you swallow the food, it goes down your esophagus or the gullet, and it goes into your stomach and the abdomen. Those are the lungs. That's the liver. This poor guy doesn't have a heart. There's the brakes. So when the food goes into the stomach, it gets ground up, and that's where the solid stuff turns to mush. And then when the stuff is turned to mush, it gets pushed out into your small intestine, this stuff. The small bowel is like a long train of sausages. And in the average human being, it's about 9 to 10 feet long. It's all coiled up inside you, and it's free to wriggle around. That's the small intestine, or the small bowel. It's called the small bowel because even though it's very long, it's narrow and caliber. Then after the food has been absorbed into your bloodstream from the small bowel, the leftover material, which becomes the poop, goes into your large bowel, which forms kind of a frame around the outside of your abdomen. And then when it gets around to the end, you poop it out into the toilet. So that's basically how your GI tract works. So all the food basically is absorbed in the small bowel. So the large bowel is actually just an accessory organ that absorbs some leftover water. Come on in. Make yourselves at home. So if you look at the intestine in cross-section, we used to think it was just a tube of muscle, like a snake. We now know it's a lot more complicated than that. There's a layer of muscle on the outside, and then there's a plexus of nerves. It's like a series of electrical connections And there are two of these layers of electrical connections in the bowel. And you think that these nerves are the keys to making the bowel squeeze and push stuff along. If you've ever watched a snake swallow a mouse or a frog, you see how the snake's body kind of pushes the thing along. You can see it from the outside. And that's basically how the bowel works and pushes stuff along. As it pushes it along, the water gets absorbed, the starch, the fat, the protein all get absorbed into the bloodstream. Another way of looking at it, this is the inside of the bowel. These things that look like tentacles on an octopus are the villi, and these are responsible for absorbing the food that's inside the channel. And on the outer layers of the bowel are these layers of muscle and the nerves that drive the push of the bowel. So, we're not talking about a cancer where there's a lump. We're not talking about a twist in the bowel. We're talking about these things called motility disorders, where the normal squeeze and push either isn't there, or it's working in a disorganized fashion, or it's overworking, it's in spasm. So things don't push along the way they're supposed to. So there's no physical blockage. These things are actually far more common than people realize. Even simple old constipation is a type of motility disorder. The normal range in Canada is you can poop anywhere from 3 times a day to 3 times a week. If you're outside that range, there's something going on. Diarrhea is a motility disorder. Things move through way too fast and the liquid doesn't get absorbed. Ladies who are pregnant with this strange nausea condition, there's no blockage whatsoever, but they're nauseous and they frequently vomit in the mornings. Why is that? Very rare in men. When we operate on people and manipulate the bowel, it causes a paralysis of the bowel, and your intestine will not work for several days after the surgery, just from us picking it up and moving it around. That's called ileus. The most common motility disorder, however, on the face of the earth is this thing called IBS, which is irritable bowel syndrome, which means the intestine is doing something outside of this normal range. There's many things that affect the motility of the bowel that we know of, and I'm not going to go into all in detail on this, but the effect of these electrical nerves on the bowel are significant. There are all kinds of things in your blood that affect the bowel, things that make nerves work, hormones. For example, when ladies are pregnant, we know that your bowels slow down. That's not because the baby's squashing the bowel. It's got nothing to do with it at all. There's something in your bloodstream that makes your bowels slow down and you get constipated. Drugs slow the bowel down. The most famous one of all, of course, is the narcotic drugs. We know that narcotic drugs are fantastic for relieving pain, but they are very addicting, and they cause the bowel to stop working. Different types of food. If you have a child who has diarrhea, and there's no obvious cause for it other than some virus going through them, you put them on the BRAC diet: bananas, rice, applesauce, toast. Those things really slow people down. And there are diseases that affect the bowel as well, the most common one being diabetes, which can actually paralyze different parts of the intestine. So this irritable bowel syndrome that I mentioned is a condition that can affect 2 million people in this country out of a population of 38 million. So it's very, very common. And it's interesting that most people who are affected are ladies between the ages of 15 and 45. And the main symptoms are lower abdominal cramps. You alternate between being bunged up and too loose, and the poop can be small in size. The pain, the cramps usually go away after you empty your bowel. This condition was originally thought to be it's just a variant of normal. There's really nothing wrong. You're just a little outside the ordinary. So for years this was not treated as a disease. But now people realize there's something, the physicians realize there is something wrong with the bowel in this condition, but we don't know what it is. So what we're going to talk about tonight, digits, is this thing blown out of proportion. So I have to say again, this is not in any textbook. This is just us here on staff in London trying to figure out what's going on and trying to figure out a name for this condition. So DIGIT stands for diffuse irritable GI tract syndrome. Also stands for these things, which gets a little confusing, but I thought this was a good way to remember. So again, it's almost always in young women. Usually starts in the teens with severe constipation. And I'm not talking about maybe going every other day. You're going to be pooping once every 2, 3, 4 weeks, sometimes every 8 weeks. Even with dynamite, castor oil, milk of magnesia, phosphorus soda, whatever else you want to take. In most people, these things just don't work after a while. The fascinating thing is that the condition may progress to include all the other parts of your intestinal tract where it becomes hard to swallow. If it affects the stomach, you get nauseous right after you eat. And in the small bowel, intense cramping. It can even affect where you pee. So the muscle of the urinary bladder where the urine is stored can get irritable. And you can have irritable bladder syndrome. So you got to pee all the time, going frequently, or you have the opposite problem. You're pushing and nothing's happening. So this condition, digits, can affect the muscle of not only the intestinal tract, but also the muscle of the bladder. So what do we do to investigate it? Back to the basic things, talk to the patient, get the story, examine them. A rectal exam is important to get an idea whether the pucker muscle down below is working properly. And then the usual blood test that we do to test if you're well nourished and to see if you're dehydrated or well hydrated. And then we put you through the scopes, and most of you in the room have been through this. We're trying to see what the inside of the bowel looks like to make sure there's nothing else going on. There's no cancer, there's no twist, there's no pinch. And we have special x-rays we can do, like CAT scans, to show us what else is going on in the abdomen outside the bowel. And then there's a long list of other fancy tests that we do that specifically test motility. This one, many of you in the room have had this done. We get you to swallow a little capsule that has marker pills in it, and the marker pills go through your GI tract. And they take several days to go through, and you can see them on the x-ray. This one, gastric emptying study, you get to eat a special treat called a radioactive egg salad sandwich, which is, you don't find these stuff at Tim Hortons, I can tell you. And when you eat that sandwich, it gets ground up in your stomach, and you can tell by doing these special nuclear medicine images as to whether the ground up sandwich is leaving the stomach at a rapid rate or not. I'll just dim the lights here so you can see this. So this is a plain x-ray of the abdomen. So if you're looking at the person from the front, that's the waist, and there's the hip bones on either side. The black stuff is air in the bowel, so that's air inside in the rectum. That's the spine. If you look over here, you see the black, that's air in the colon. You see the little white things, look like lifesavers? So those are the markers moving through the bowel. So this is 24 hours after the person has swallowed this capsule, and the markers are in the colon. If they move around at a normal rate, by the time you do the next x-ray on day 3, the markers are gone. If the colon is moving very slowly, the markers are still in here, and we know, therefore, that the bowel is not moving stuff along at the normal rate. Turn the lights back on again. I just want to take you through a few examples of what people are going through with this. I change these cases every few years because I don't want people to get hung up that, oh, that's me. There's a lot of people with this, and it may sound like you, but it's probably not. Although you never know. So, first person, constipated since she was a teenager, bowels moving once every 2 weeks, a lot of bloating and cramps. And we did a bunch of studies, and the pressure test in the rectum was normal. This test is a test to see if you can actually empty the rectum. It's done over in the x-ray department at St. Joe's. And this showed that the person could empty the rectum well, but the marker study, the lifesavers, moved very slowly through the bowel. So, this goes way back. Back in 1986, when we just started doing this, we took the colon out and joined the small bowel. The end of the small bowel is called the ileum. We joined it onto the rectum inside the pelvis. And this lady did very well. Went from having bowel movements every 2, 3, 4 weeks to having 2 a day with no laxatives until 5 years ago. And then started having trouble again. And the investigation showed that the joint we made looked irritated, and the rectum below the joint looked large. So she's fed up with this and wants to go through more surgery. And now the question is, do we just redo the joint, try and make another joint in there, or do we say the bowel downstream, which is the rectum, is not working properly, it's swollen, it won't empty, therefore she should have a temporary ostomy pouch to see if that would work. So we decompress the bowel to the outside. So when they make an ileostomy, we bring the tube, we divide it inside the abdomen, close the downstream end, and we bring this end out to a pouch, and the poop comes out into the pouch. And this whole process came about because we were doing ileostomies for other diseases and realized by chance that some of these people who had motility disorders actually got better with the ileostomy because we're venting, we're decompressing, we're letting the bowel empty finally when it couldn't empty the normal way. The other operation we're doing is when we take the colon out, we join the small bowel here onto the tube of the rectum up inside the pelvis. So that's called an iliorectal anastomosis. And Vinny may say a few words about this, but it's been our impression that this sometimes works, but the ostomy pouch is much more reliable. This young woman had such severe pain from her problem that she ended up having a hysterectomy in both her ovaries out at age 22, which is way too young to be taken out of uterus and ovaries. It was thought that she had PID, which stands for pelvic inflammatory disease, an infection in the ovaries. But from talking to her, she'd been constipated for years and then started having problems with diarrhea and eventually went on to have really severe pain. We, out of desperation, we did an ileostomy, which really helped her, and then we eventually took her colon out. And I thought, she's going to be okay now. But as time went on, the process spread through her intestinal tract. She got fed up and eventually could only get by on intravenous fluids. And she had intravenous lines in to try and keep her alive and keep the fluids going, and keep her hydrated and keep her nourished. But she was at home and on a lot of narcotic and accidentally vomited and choked on the vomit. And she was at home and that was it. She had a respiratory arrest and died. This lady's 40, again, constipation since a teenager, bowels moving every 3 to 6 weeks. And we found that things moved along very slowly and she couldn't empty her rectum. She did not want to have the pouch done on the outside. So this was about 15 years ago, I think, when we did this. And we took the colon out and reconnected her inside. Didn't work. Still crampy, diarrhea, and really felt horrible. So 3 years later, she came back, and we decompressed her, brought the bowel to the outside. Right away, symptoms gone. And so far, she's now 5 years down the road and is doing very well. This is a disease of women for reasons we don't understand. We've got 3 or 4 men, or maybe 5 men now, who we recognize have this condition. So this man was okay until he slipped and fell down the stairs, got bad pain in his back. And then all of a sudden, bladder stopped working. And he eventually required a bladder pouch on the outside because the bladder wouldn't work and he kept getting horrible kidney infections. And if you lose your kidneys, you're on dialysis. So the bladder was diverted to the outside, and then I didn't meet him until a couple of years later. He had many, many operations for what's thought to be bowel obstructions, which when he was sent to me sounded more like constipation problems. And indeed the study said, this is not twisting, this is not pinching, this is actually a motility disorder. So we took out the colon and did an ostomy pouch on the outside, off laxatives, much better now with nausea, and the pain requirements are much less. The main problem is taking narcotics for are the back pain that he started out with from falling down the stairs. So even in the few men we've been able to find with this condition, the operation seems to help. So the symptoms then are dependent on where it is in your intestine. In most people, it's in the colon or the large bowel. So constipation or diarrhea. And this outlet obstruction is where you just can't empty the rectum. Even if it's full, down there you can't go. If it's in your esophagus, which is very rare, it's hard to swallow. If it's in the stomach, you get nauseated and you can't eat very much. You eat a couple of mouthfuls and you're full, you gotta stop. Most people, you can eat. Like the average guy, you can chow down in a hot dog eating contest and eat 20 hot dogs, and you're okay. These people can't eat much more than a few mouthfuls because the stomach will not accept anymore for reasons we don't understand. If it affects the small bowel, then the problem is related to the cramps, because the small bowel is very powerful, and when it goes into spasm, it hurts. If it goes into spasm and you have an ostomy pouch, it's so powerful that it can actually pull the opening of the ostomy down flush with the skin. So it actually pulls it towards the inside. We call that turtling. It's like a turtle's head pulling back into its shell. And finally, we talked about the symptoms if you have it in the bladder. So what does this do to you? Well, you can't eat. So you lose weight, you become malnourished, you're very susceptible to infection, pneumonia. If you're dehydrated, you're tired all the time, you're thirsty, you can't do much. If you're in pain all the time and you get hooked on narcs, you're in a really difficult situation. So the narcotics not only produce an addiction in some people, but they also make the bowel symptoms worse because of the side effects. People develop personality disorders, and I tell my residents and students, if you have cramps all night, and you're bloated and you feel horrible, and you can't sleep, it's like being on call every night. There are regulations now in the medical profession where we are not supposed to be on call every night, because if you're up and you don't get enough sleep, you don't do a very good job the next day. So you people who aren't getting any sleep, you can't function. You get to visit many doctors though, which is, you may say, well, it's great, but it's not great, because you're being passed from one person to the next because we can't figure out what's wrong. And some people end up going through multiple surgical procedures trying to figure out, well, let's just take this out and see if it makes you better. And that's a huge leap of faith, and even for us doing the pouch surgery and the intestinal bypass operations, we are treading unknown waters here in many situations and hoping it'll work. But we're doing it with enough evidence that we can tell the patients, yes, we know from all the people we've done so far, this should help you, even though it's not in any of the textbooks. So we've got probably around 200 people now who we think have this, and we've collected these people over about 15 or 20 years. And we don't operate on everybody, only the people who are at the end of the rope. The most common procedure we do is take out the large bowel and do an ileostomy pouch. In some people, we can hook them back together and it works. A lot of people say, why don't you just take my bowel out and give me a transplant? Well, it's actually a good question because you can do it. Right now, though, the small bowel transplant is an experimental operation, and it should not be done unless all else fails. People take a long time to recover from these operations, much longer than the average patient who has cancer or a twist. It seems to hurt more, the bowel takes longer to start working again, and afterwards, it's hard to keep people hydrated. They tend to lose more fluid than the average person does from the bowel. Can this condition kill you? Yes. So over 15 years, we've lost 10 people now. Young, active, otherwise well people who have died from complications from this. 2 threw up and choked on their vomit. 1 was on TPN like this, on intravenous feeding, and she got up at night and tripped over her IV, and the IV got disconnected. And when you disconnect the line that's going right into your heart, you suck air into the line. And when you suck air into an IV line in large volumes, that's it, your heart stops. 7 people have died from intravenous line infections from the lines. These are lines that are in for months or years. If you don't take good care of them, or you don't recognize when something's wrong, you can get into serious problems. So we tell all our people who have these lines in for intravenous fluids to be very careful and know the signs of infection. If you catch it early, it's easy. If you don't recognize it early and you're at home, after several days you're in big trouble. So what is this? In all the people we've taken the bowel out, the pathologists who look at the bowel through the microscope are telling us, looks normal. Why are you people taking this bowel out? Now Biniam's going to say a few more words about that. Why is it almost exclusively in ladies? Is it hormonal? Is it something to do with estrogen and progesterone? Why do people who are pregnant get constipated? Something to do with estrogen and progesterone. Is it something wrong with the nerves? Is there some biochemical substance that is circulating that's causing this? What about the narcotics? Now, there are new narcotics coming out that allegedly do not affect the bowel. Now, we don't have them released to our use yet, but they may be a big step forward where you get pain relief, but it doesn't affect the bowel. And finally, the stress and anxiety thing. Oh, your bowels are, you're just stressed out. Next page. So we know that stress and anxiety have a huge impact on your gut function. But if stress and anxiety cause this, every medical student and surgeon in this hospital would have digits. Right? Every police officer out there putting their lives on the road every day on the line would have digits. So there's more to it than just stress and anxiety. So what do we do? First of all, the key thing is to recognize there's something wrong with your intestine. It's not imaginary. You've got to keep yourself hydrated, keep yourself well nourished, and recognize, especially for physicians, that the personality disorders, the anxiety, the stress, the anger, is a reaction to being chronically in pain, not getting enough sleep, and being unhealthy. We use drugs to try and make the bowel work better. Prokinetics make the bowel empty downstream so you're not nauseous. The laxatives push the colon to make it empty when it's not working. We have GI psychologists here who can talk to people who are having problems, try and give them ways to cope with the problem. And we do operate on some people to try and bypass the problem or take the problem out. We've learned a lot over the years about what you should do. First of all, don't eat big meals. Small meals. Frequent snacks during the day. Liquids are better tolerated than solids. And how do you deal with the pain? I talked about that earlier. Coping strategies. Try and distract yourself if that's possible. And be careful with the narcotics. They relieve the pain, but then they make the pain worse because of the effects on the bowel. Laxatives, yes, they do help early on in most people. And again, most people who have this condition are being told by physicians, for God's sake, don't take laxatives because your bowels won't work after a while. The bowels pack it in. Well, your bowels already packed it in. You've got nothing to lose. So you might as well use the heavy-duty laxatives. And if they stop working, then we've got surgery to help you out. Probably the worst thing, you're dealing with uncertainty. This is something we don't understand. And you're dealing with physicians and nurses who have never heard of this. And the standard answer from the docs is, well, you know, this is all in your head. It's not in the textbook, so therefore it doesn't exist. So we have to train ourselves to be open-minded that we don't know everything. We've also learned the value of having a support group. And Tanya's going to talk about this. Vinny will talk about the research side. We need to educate patients and healthcare professionals. I'm doing that now, and actually, when I'm out giving talks about cancer or twisting the bowel or whatever, I usually throw in a quick talk about digits. And people look at me like I'm crazy. But I get a phone call a week later, hey, you know that talk you gave us? I got somebody who's got that, you know that? And slowly the message is getting out there. Probably the number one thing, though, is the last support. It's friends and family. That's why You guys aren't here on your own tonight. You've got plenty of friends and family with you. So, what are we doing that's new? Well, we're looking at this. First of all, is this an abnormal response to hormones because it's so common in women? Or is it just an exaggerated response to the narcotic drugs or something in your drug, in your bloodstream, that's acting like a narcotic and stopping the bowel from working? So far, haven't come up with anything. Is it produced by constant emotional stress or trauma? No. It's aggravated by it, but it's not caused by it. Is it hereditary? Maybe. We've got a couple of mother-daughter combinations in the collection of patients, but that's pretty rare. It may just be a chance happening. Is it a sexist condition? Absolutely, 100%. Well, 95%. We've only got 5% of the population being male, but it certainly is affecting women far more commonly. Does it affect all patients similarly? No, it's all over the map. There are a few common threads, but they're not the same. The other thing that's new is fundraising successes. And thanks to a very dedicated group of volunteers, we've been able to raise funds which are going into our research account here, which is paying for some of the statistical analysis and all the other administrative expenses you have to go through to do some of the research on digits. And Brittany will talk more about that. You may not know that there have been book sales at Anne-Marie Barker's place in South London. And up on our floor on the board, on the 8th floor, we have a snack bar, and all of the proceeds from that go to the Digits Research Group. Last 2 years ago, this coming February, we had a fundraiser just down the road at Windermere Manor, and we're going to have another one in February this year, which Tanya will talk about. The Three Musketeers here are the prime drivers behind you being here tonight and getting the whole thing organized. Tanya's on the right, Nellie in the middle, and Anne-Marie, who is the coordinator on our floor on the 8th floor. They've been the driving force behind this and deserve a huge amount of credit. So we now have a patient advocacy group, a website, an executive, we have fundraising underway. The next gala is coming up in February. In the dark winter days of February, you can warm yourself up and come to the gala and support the group. The key thing for me that's changed in the last year has been having a person like Biniam who has the wherewithal and training to start doing some meaningful chart reviews and assessments of what we do to see if it actually does work or not. I've got individual people saying, oh, you know, that surgery you did, it really helped me. But you've got to do it and prove that it works in a larger group of people.